And then, to summarize, is Hope Rugo, and she needs no introduction, and she's from University of California, San Francisco, in person. All yours, Hope.
Thanks very much, and thank you for the organizers and our chairs for inviting me to discuss these two important studies. And of note, I'm not discussing the first presentation, the excellent presentation by Dr. Bianchini. These are my disclosures. We just heard additional updates for Keynote 522, focusing on sensitivity analyses and subsets in both Keynote 522 and 355. The overarching questions, which we heard in the discussion, that arise include the association of PCR with event-free survival and the discordance of PD-L1 in predicting the impact of checkpoint inhibition in early versus late disease. There are, of course, other questions, including optimal post-neoadjuvant therapy, that we will briefly discuss. Keynote 522 randomized almost 1,200 patients with high-risk early-stage TNBC to receive pembrolizumab or not in both the neoadjuvant and post-surgical setting, showing an increase in PCR and most recently a significant increase in event-free and distant recurrence-free survival in patients receiving pembrolizumab. About half had node-positive disease, 3/4 were stage 2, and about half were premenopausal. There were 5 sensitivity analyses planned in the study. This table shows variations in censoring compared to the primary analysis. 2 analyses are highlighting censoring based on post-neoadjuvant therapy, which in all cases was capecitabine, and censoring based on a positive last surgical margin. As you can see, regardless of variation in censoring, event-free survival remains similar in terms of hazard ratios. On the right, you can see the data from the group censored for capecitabine and the group censored for positive surgical margins, but the numbers are very small, making any impact unlikely. Event-free survival was superior with pembrolizumab in all subgroups represented here, and in particular, regardless of node status or stage, as listed on the right. In 2 prior analyses, we see that the impact of pembrolizumab on PCR appears to be greater in node-positive compared to node-negative disease, with some trends in the EFS in subset analysis. While it is certainly possible that the impact on PCR by node status is by statistical variation, more likely it is related to the differential impact on PCR by stage, as shown here from the first interim analysis, with relatively greater impact in higher stage disease. In addition, in the 4th interim analysis of Keynote 522, we saw that patients who achieved a PCR had a relatively good event-free survival regardless of treatment arm. In contrast, those who did not achieve a PCR fared much better with pembrolizumab. In the lower part of this slide, I have added the outcome data from the recently published ECOG 1131 trial with 3-year disease-free survival following post-neoadjuvant capecitabine or carboplatin in basal-like disease, showing clearly that we are making progress in the outcome of patients with high-risk early triple-negative breast cancer by adding immunotherapy. How can we explain these findings with the differential impact on stage and by node status and the differential impact on PCR versus event-free survival? Indeed, response to neoadjuvant therapy remains important as a predictor for long-term outcome. This figure shows the strong impact of residual cancer burden, or RCB, on event-free survival in patients with TNBC enrolled in the I-SPY 2 trial recently published by Fraser-Simmons. On the right, you can see the remarkable left shift of RCB from the addition of just 4 doses of pembrolizumab to standard neoadjuvant chemotherapy in I-SPY 2, with paclitaxel alone in purple and the addition of pembrolizumab in yellow. The mean RCB is 1.68 with paclitaxel and decreases to 0.46 with the addition of 4 doses of pembrolizumab. Indeed, in the first 600 or so patients enrolled in Keynote 522, a left shift in RCB was seen, suggesting that this shift is responsible for the improved EFS seen in the non-PCR group, and at least in part responsible for the differential impact on PCR by node status. We hope to see RCB data from this trial next year. The treatment efficacy score presented by Marzik and colleagues on behalf of the I-SPY 2 investigators at ASCO this year, it may be a better way to assess the efficacy of novel neoadjuvant therapies by evaluating the entire spectrum and shift of RCB across treatment arms, rather than looking at PCR alone. With any new therapy, we need to balance efficacy against toxicity. As we have seen in other settings, the combination of a checkpoint inhibitor with chemotherapy is associated with a relative increase in immune toxicity, which then decreases with a checkpoint inhibitor alone. The major toxicities are endocrine and skin, and I've highlighted those that fall into the same category, such as adrenal insufficiency and hypophysitis, which have the same impact on patients. In the upper right-hand corner, I've shown for your interest a non-serious toxicity with patchy hypopigmentation of skin, vitiligo, and hair, called poliosis. This table summarizes the neoadjuvant studies with checkpoint inhibitors to date. NeoTRIP did not show improved PCR, and notably, that trial did not include preoperative anthracyclines. And an interesting poster spotlight, highlighted in pink at the bottom of this slide, will discuss the impact of anthracyclines on the modulation of the immune microenvironment at this meeting. Of note, 2 small trials showed an impact on both PCR and long-term outcome with the checkpoint inhibitor, given only in the neoadjuvant setting, most recently with the remarkable outcome data seen in the phase 2 GS1-03 trial. There are still, of course, a number of unanswered questions. Does everybody need a checkpoint inhibitor? Perhaps studies, as we saw in the first presentation today, could help us understand which patients might do well with chemotherapy alone. In addition, we need to understand the balance of risk and toxicity. Are there patients whose risk is so high of an immune toxicity that we should not give them a checkpoint inhibitor? That may take us a longer time to understand. What's the optimal chemotherapy backbone? Does everybody need a carboplatin? Brightness showed an improved PCR and event-free survival, but not overall survival with carboplatin, as you can see in the post-hoc analysis shown at the bottom of that table and presented at ESMO by Dr. Leubel. Does everyone need a year of pembrolizumab, even with a PCR, given the intriguing data from GS1-03 and previously the I-SPY trial? In those without a PCR, should we combine pembrolizumab with chemotherapy or a PARP inhibitor to optimize outcome? Of course, we don't know the answers to those questions, but here's a potential roadmap for the treatment of early-stage triple-negative breast cancer. Patients with T1C node-negative disease, I believe, should be treated in the neoadjuvant setting because we can optimize their outcome by understanding response. However, these patients should be treated with chemotherapy alone, as we don't have data with checkpoint inhibitors in that setting. Patients who have node-positive or T2 or greater disease should receive the checkpoint inhibitor pembrolizumab with a chemotherapy backbone, including an anthracycline. Questions regarding what to do with a patient who has PCR or non-PCR are listed on the right. Should we complete a year of pembrolizumab or stop with no further therapy? There is additional toxicity, although decreased from the neoadjuvant setting. Should we give capecitabine or olaparib based on germline mutational status alone, sequentially with pembrolizumab, or in combination? In yellow, I've shown you a non-validated Twitter poll that I completed answers on yesterday. And this is an update from the summer when the first data was presented. And I have to say, the results are identical, so no one's ideas have changed in the last few months. Out of almost 200 responders, almost everybody would give a combination of therapy in patients who don't have a PCR. In patients who have a PCR, almost everybody would complete a year of pembrolizumab. Hopefully, we'll understand more of these details in the future. And there are ongoing phase 3 trials with checkpoint inhibitors in triple-negative breast cancer. The largest trials are in bold: the neoadjuvant B59 GEPARDUS trial and adjuvant Impassion 30 trial with the atezolizumab, and the post-neoadjuvant SWOG 1418 trial with pembrolizumab. We hope to see results in the near future from these trials. Now let's move on to Keynote 355. This trial, which included varied chemotherapy backbone, demonstrated an improvement in progression-free and overall survival in the 38% of patients who had PD-L1 positive disease defined by a checkpoint, a CPS of 10 or more, a combined positive score. The current presentation evaluated the impact of varied CPS on both overall survival and progression-free survival, demonstrating that a CPS of 10 is clearly the optimal cutoff for differentiating benefit from pembrolizumab and confirming pembrolizumab plus chemotherapy as a standard of care in this population. What are the questions for the use of checkpoint inhibitors in patients with metastatic triple-negative breast cancer? I'll discuss the first question about PD-L1 in metastatic disease, but not early-stage disease, in a moment. Clearly, the test that you order should be matched to the planned checkpoint inhibitor, and we look forward to additional data from both 355 and 522 about relative overlap. But you can see on the right in a sub-study from GS1-03 that there is incomplete overlap in terms of the two antibodies and tests that have been used to define PD-L1 positivity in breast cancer. We don't understand the lack of benefit from atezolizumab in GS1-31, and I think it's important to explore the heterogeneity of triple-negative disease in that trial population, as we clearly saw differential immune activation in the first presentation today. It does seem that the statistical design of GS1-30 is responsible for the US withdrawal of approval, rather than, in fact, a difference in efficacy. For excellent responders, can chemotherapy and eventually immunotherapy be discontinued? And when is it optimal? How long should we be continuing the combination? And how long should we continue the checkpoint inhibitor alone? Certainly in my own clinical practice, in those excellent responders, it's difficult to know when to stop the checkpoint inhibitor, but sometimes toxicity tells us the answer to that question. At some point, we need to stop therapy and understand what happens to those patients. Lastly, only 38% of patients benefited from pembrolizumab. How can we amplify the immune response in those patients who do not have PD-L1 positive disease to further extend this benefit? And can we extend the efficacy to other subtypes? There are ongoing studies evaluating this question. Perhaps we can understand the differential impact of PD-L1 positivity comparing primary to metastatic disease by looking at this data from the Pustai lab. Here, they had paired samples from early and metastatic disease and showed that there was a decrease in PD-L1 expression as well as TILs, and they evaluated this in full section and in tissue microarrays. On the right, you can see a figure from a recent excellent review from the first speaker today, Dr. Bianchini. Here you can see the immune differences between primary and metastatic disease leading to immune escape. This is clearly complicated by mutational complexity under the pressure of treatment. How can we amplify the immune response? Various studies are evaluating potential ways to amplify this response, including induction with chemotherapy, combinations with other immune active agents, and combinations with antibody drug conjugates, PARP inhibitors, and radiation. I've shown a few examples of completed and ongoing trials here. In addition, do listen to the oral presentation of the Nimbus trial in high tumor mutational burden disease at this meeting on Wednesday morning. Here's a possible roadmap for the treatment of metastatic triple-negative breast cancer based on PD-L1 testing and germline mutational status, as well as disease-free interval impacting the choice of chemotherapy, and of course, tumor mutational burden. Future trials will further define the optimal positioning of antibody drug conjugates such as sacituzumab govitecan, and as I mentioned, are actively studying combinations of ADCs with checkpoint inhibitors. With that, I'd like to thank you for your attention and thank Dr. Schmidt and Cortez for sharing their slides, my colleagues at Merck for helpful clarifications about the sensitivity analysis, Drs. Pustai, Yao, Simmons, Bianchini, Mittendorf, and Sirigliano, as well as Laura Esserman for helpful comments and review of this discussion. And I'll end with a quote from Mark Twain: "The secret of making progress is to get started, and we're clearly on the right path for triple-negative breast cancer." Thank you.